Hello everyone, I'm Dr. Kim Se-jin. This is a case discussion to share clinical difficulties and find the solutions. We have master clinicians, Dr. Park Jong-hyun, Professor Kim Young-taek, and Dr. Kim Kyung-won.
안녕하세요.
This is a case of a 75-year-old man. He came to place implants on the maxilla. PMH is hypertension. At number 13 and 15, implants will be placed. Number 15 only requires sinus lift, but number 13, sinus lift needs to be done with GBR. Can I do the two procedures at the same time? What is the prognosis? Number 13 and 15 have different teeth axes. Can I do implant bridge there? So a dentist sent us this case. What do you think about this? As I see it, sinus plus a GBR, that must be burdensome to the dentist. Between canine and premolar, I'm not a prosthodontist, so I'm not sure. But the angles would be different when you place it in the canine or premolar. Sinus and GBR, sometimes we do them together and sometimes one is done before the other. I'm a clinician. As a researcher, I also studied this. The problem with the implants splinted when they have different teeth axes. So I believe this is going to be an exciting discussion. Dr. Park Jong-hyun, looking at this patient's case, I noticed the left side that can be done pretty easily. There's no reason to extract number 16. If number 16 is not very good, if there is no number 16, it could have been a simpler case. Why does number 16 is very well treated, endotreated, to make the situation more challenging? So simpler is the best approach. Let's listen to our clinicians, how they would address the problems. Dr. Park Jong-hyun? Let me talk about with my case. If you look at here, number 27 is not very good. If you do proper endo treatment, when it is extracted like this, we can save number 27. However, extracting number 27 would be agreed upon by most dentists, but I was very lucky. Number 27 was not very good. Therefore, I could avoid sinus lift at number 26. There is no reason to extract number 16 in the case under discussion. However, you can do strategic extraction like this, then the challenging case can become an easy case. The bone width at the premolar is 5.9 millimeters. Once we thought the more we have buccal bone, the better. Exposing palatal bone is not very good. The bone width was not that narrow, but ridge split was done. And buccal bone graft was performed. 2 years later, there is enough bone. However, the concept is changed recently. Even though the outcome is not as favorable, I could have placed the implant a little bit deeper, even with a couple of threads of the implant exposed at the top, to make the case more comfortable for the patient as well as the dentist. This idea occurred to me quite recently. Definitive prosthesis To your recall, I could see it is pretty well maintained. I believe more buccal residual bone is better, but I think smaller diameter implants placed deeper could have been also very good. What do you think about this? Do you think bone graft had to be done? Was it immediate placement? No, not immediately after extraction. How long did you wait for the healing? Usually, when I extract, for this type of healing, at least 2 to 3 months. Number 7, I waited for about 3 months. 3 months? Depending on bone, you don't have to do it. The shape of number 7 root, toward the apex, it got narrow suddenly. There's a criteria to do bone graft or not. At least 2 millimeters of buccal bone, which will not be resorbed completely. If the gap is less than 2 millimeters, spontaneous healing can occur. So if the gap is less than 2 millimeters, you don't need to do bone graft. Did I really have to do bone graft in the premolar area? I think I would not do bone graft. I also do not use autogenous bone these days. That's the trend. We do minimal invasive surgery. In this case, at number 6, a sinus graft would have been done in the past, and we also use a bridge over implant today, so minimal surgery would be better. Thank you very much for answering my case. So this is how it is finished. What I want to say is that when sinus lift is very challenging, you don't need to place the implant there. Strategic extraction can be made to make it an easier case. Placing an implant inclined like that, the placement path, in the past, if we placed along the bone direction, it was not considered good, and we were supposed to place along the long axis of the tooth, but then palatal threads can be exposed. So we secure the buccal bone, sinus is hydrolifted, and additional bone graft is done along the long axis of tooth. The bone is secured. However, do we really need to do the procedure? Come to think of it now, the bone width is enough and the sinus is lifted properly. The outcome is not bad, but come to think of it again, incline the placement of implant. Is that okay? Angled abutment used in splinted implant. I haven't experienced any problems with that. To place the implant along the axis of the tooth, do we really need to use that procedure? That's still a question to me. If I were the patient of this case, I would ask the surgeon to place a non-hex 3.6 millimeter diameter implant in the direction of the bone. Next case. We have to do bone graft here because the ridge is very narrow. A guide was fabricated. At number 26, the sinus was hydrolifted. If blood is suctioned out without air bubbles, you can say the sinus is safely lifted. The guide is used only for the initial drilling, but it was worth it because it sets the direction of the ridge splitting. I made a big mistake here. This portion, sinus was lifted, therefore I should have extended the incision horizontal incision distally this much. I made the incision too small, fearing the high-speed disc may tear the sinus. The buccal bone was slightly fractured, so additional bone graft was done before it was finished. If I made the osteotectomy longer along the green line, it might have been better. The placement direction was a little bit different, but it was like this, 1 year recall. I didn't like it very much, but considering very narrow ridge, it was okay to be maintained. 2-year recall, bone is resorbed a little bit, but no problem in the maintenance of the condition. Placing implant in the long axis of the tooth, do I really need to worry about that? I don't think so. Non-X fixture is used, which is more resistant to vertical fracture, so I have a little bit peace of mind in that respect. I don't think this creates occlusal problem as well. What do you think? If I don't place the implant along the long axis of the tooth and use an angled abutment, is that a problem? Regarding the using the angled abutment, there is the answer. If you ask implant dentists if they place implants along the long axis, most of them would say no, so angled abutments need to be used. I believe the problem here is number 3. Number 3, 4, 5 need to be restored. As you said, if the implants need to be in the bone, the tooth axis will be all different from each other because it is along the arch. Number 3 would have labial version, and number 4 and 5 will be along the posterior. It is not just divergence, it is a 3-dimensional divergence. That's why I believe the dentist sent us the question with this case. I believe the angled abutments will no doubt be used. Do I need to place the implant along the long axis of the tooth even with additional procedures? No. We talked about minimal invasive procedure. So we need to avoid the GBR or sinus lift as much as possible. I talked about this before. In a case discussion, one of the culprits of the periimplantitis is the bone augmentation. If you want to use the implant for a long time, we need to avoid the GBR as much as possible. It's inevitable to do it in thin bone. I think it's appropriate to use the angled abutments prosthetically. I agree with that. We used to use autobone, block bone, and I also felt a sense of accomplishment after the procedure. As Professor Kim Young-taek said, from the long-term perspective, the host bone would have long-term influence. So these days, I say like this, patients come to us to place implants to be able to chew, whereas bone graft is something a dentist has selected. If it goes wrong, it can cause more complaints from the patients. Today, I also pursue minimal invasiveness. Thank you very much. Number 14, I thought implants would be difficult to place there. He came to my clinic after extraction at another clinic 2 months before. That portion is not very good, so I decided on cantilever. Ridge split is done at narrow ridge. The sinus was hydrolifted first. Ridge splitting was done. 2 implants were placed along the long axis. After prosthesis, I don't understand why the unfavorable area below the cantilever, the bone fills up. That's a mystery. So what I want to say for the case under discussion, if a mesial cantilever is used here, I don't think prosthesis without cantilever would be a problem even though the implant was not placed along the long axis. If the crown is short, the prosthesis can fall out and it would be a problem. I don't think placing an implant not along the long axis of a tooth is a major problem. I think using a cantilever is even worse than that, so I don't really worry about this. Beneath the cantilever, bone is filled up. With the mesial cantilever, it is finished. Regarding the case under discussion, this is what I have thought about. Doing the two procedures, sinus lift and GBR. If I say that again, we can consider a strategic extraction to avoid difficult procedure. If we do the both procedures, if everything goes okay, it'll be good, but it's very difficult and challenging case. When the axis of 13 and 15 are different, is implant bridge okay? I believe it's okay, especially when the antagonist tooth is RPD. There's no other choice but to do this. Thank you very much. Next, Dr. Kim Kyung-won. Dr. Park is doing very good sinus surgery. I don't know why he calls it very challenging. I talk about this during lectures. If we do the surgery without additional procedures, it would be best, but sometimes we require additional procedures. Then, sinus lift or graft, more predictable and reproducible, predictable procedures need to be done. So sinus lift should be done before GBR. Let me introduce a similar case of mine. The patient was not referred to me from the beginning, and the patient came. Only teeth existed in the anterior region, and the mandible is not very good. It was planned to place implants at 14, 16, and 24 and 26 with bridges. I think the referring dentist thought he could easily place implants in quadrant 1. Quadrant 1, implants were placed by the local clinic, and the dentist placed 14 and 16. Number 16 with the sinus graft. As you can see, similar to the case under discussion, due to canine, the angle of number 4 and 16, the paths are not right. The dentist didn't think it would be a problem, but buccal dehiscence is observed at 14. On the other side, 24, the ridge is knife edge. So the referring dentist asked me to place implants there. The roots are still remaining, which will be extracted later. 24 is placed first, and sinus graft is done distally. Sinus membrane is lifted. 2 implants were placed with a sinus graft. As I mentioned before, allograft is covering the host bone, and xenograft is placed over in a layered approach. At number 24, the ridge is very narrow, so there is a possibility of exposure. So GBR is done. These days I use titanium mesh, so Osbuilder from Austin is planned there. Allograft is covering the buccal side of the implant, and xenograft is placed over it. Titanium mesh, and at 24 GBR is simultaneously done. As you can see, the referring dentist placed implants in quadrant 1, and the dentist asked me to place 2 implants at quadrant 2, 24 and 26. At 24, I did a GBR. I used a titanium mesh for sufficient GBR. In February 2019, I placed at 24 and 26. About 5 months later, the referring dentist did a second surgery, extracted the residual root at number 22 and 23 and placed implants. I asked the dentist to send me the picture of prosthesis. 6 months later, at 24, GBR is maintained. As Dr. Park said, one thing is regrettable. 24 and 26, the custom abutment, the bottom portion is too low, and it is regrettable that it is that way. Until December 2019, for a little bit less than a year, the GBR is maintained and no problem with the sinus. On the other side, implants were placed, but the path of the implants not very good. The long-term prognosis, we need to wait a little bit longer, and we don't really need to be concerned about doing GBR and sinus lift together. Thank you very much, Professor Kim Young-taek. I agree. Simultaneous performance of sinus lift and GBR can be done. After extraction in quadrant 1, the picture was taken. Implants are planned for 15 and 16. Vertically, the bone is resorbed and sinus is lowered. These days, I don't try to use lateral approach. I use crestal approach first. And if the membrane is torn or the volume is not good enough, I use the lateral approach. So using the crestal approach, implants are placed. Sinus pneumatization and atrophy coexist at the same time in the maxilla. So unexpectedly, in many cases, we need to do both procedures together, sinus lift and GBR. We cannot just make bone. Bone needs to grow from bone. It is not something made. Therefore, we need to secure the area where bone can grow. If sinus is very thin and the area for graft is very thin, there's a limitation in growing bone even though the potential is pretty good. We need to be able to identify from our experience how much bone can be augmented. Very renowned Italian speaker can grow 12 millimeters vertically, which cannot be done by everyone, but growing 5 to 6 millimeter bone can be easily done. Bone growing potentials needs to be considered. Then sinus lift and GBR can be easily performed. While I do the GBR, I didn't do decortication. When the cortical bone is broken, we cannot expect the bone to be maintained. It can be resorbed. Cancellous bone is exposed, and we don't have to do decortication as backed by papers. The bone graft would be good enough. Sinus is lifted. The path of placement cannot be very good. When we place implants in atrophied ridge, I was impressed by Dr. Kim Kyung-won's placement of implants in atrophied ridge. But the compensation can be made prosthetically as long as implants are surrounded by bone. On the other side, which is not exactly the same case, PAO, SFE, bone added osteotome sinus floor elevation is done. The membrane is torn, a hole is made. Do we need to give this up and approach laterally? No. In the middle, a hole is made. In the molar area, we tend to place wide implants, so it is a wide hole. We can see it clearly. Low-priced collagen membrane can be used to facilitate soft tissue healing. Long-lasting collagen membrane may interfere with the healing, so easily resorbed membrane is used. They can support the bone graft material. You can cut it in small size and attach it there to block the hole. Before that, you need to use various instruments to detach the membrane. Using the transcrestal approach, you can address the problem, maybe not very easily. You don't need to be scared of sinus membrane tearing. It can be mended. It was torn and very thin, so I used the two-stage approach. As you can see, bone graft material is lifted. Healing abutments were connected 5 months later. After 2 months, prosthesis, it is maintained after 2 years. GBR site bone level is maintained. I'm not sure about the long term. If it is stabilized like this at the beginning, I believe the long term prognosis would be okay. May I cut in, please? Perforation can be made during crystal approach. I recommend the lateral approach in my lectures for ease of repair, but Professor Kim Young-taek blocked the hole, the perforated hole made in the middle. It was very impressive. As Professor Kim said, decortication of cortical bone. Dr. Park also did that in the upper posterior region. As Professor Kim said, some papers say it is not necessary, especially in the lower posterior or anterior region. The cortical bone is thick, so decortication can be beneficial. I hardly do it on the maxilla, especially in the posterior region. The cortical bone there is not very thick, so I don't think it is needed there. I don't do it even in the anterior region of the maxilla, unless it is a special occasion. I am really impressed by the surgery done by the prosthodontist, Dr. Park. In my view, I don't think it is necessary in the maxilla. I agree with Professor Kim. Thank you very much. I will not do decortication in the maxilla. According to the papers, there are holes in the cortical bone, and we don't need to make holes when the cortical bone is very hard, like it doesn't bleed even during drilling. Then we can do it. Regarding the tooth axis, number 13, as I said before, to place an implant or to deliver prosthesis, it's troublesome in reconstructing a tooth. For number 13, we need to decide whether we will provide the canine guidance or group function. It usually moves to group function if an implant is placed. And you may think we don't have to do anything at number 13. It is canine, so it is still important. We need to think about whether it will be placed as a canine or as a group function. I want to talk about this. 1, 3 implants are placed as singles. 2, 2 implants are placed with 3 prostheses split together. and 3. 3 implants are placed and the prosthesis is all splinted together. Which one do you prefer? We need to consider the economic situation of a patient, so I will choose number 2. 2 implants are placed and the prosthesis is splitted. Do prosthodontists choose number 2 in general? As a private practitioner, I want to place 3 implants. I always use the same protocol. 1 single in premolar and 2 molars splinted. Actually, recently, I don't do prosthetics. Prosthodontists plan the prosthesis. Recently, they use bridges a lot. About 10 years ago, we used to place an implant per missing tooth. Sometimes we placed 2 implants for number 17 missing in the mandible. So placing 3 may be right. So when we place the 3, does it have to be 3 singles or 1 single and 2 distal implants splitted together? But I think these days people tend to avoid splitting all 3 together. I discussed about this with the prosthodontists. Mostly try to choose number 2, and the papers are saying number 2 is the answer. In the long term, when implants are close with each other, cleansing is difficult and causes periimplantitis. I also used to place 4 implants for number 4 to 7. I place less than that and use a cantilever where the bone is not very good. These days, implants are not placed close to each other, and the distance between them needs to be respected. This paper published 2019. So number 2 is the ideal solution. For the case under discussion, the area is not wide enough, so only 2 can be placed, but if we place 3, 2 can be splinted. It's not a bad idea. But I have experienced patients who insist on receiving 3 implants instead of 2. Placing 3 can be done. In the past, we splinted them in tripod positions to hold them together. These days, they tend to splint 2 and leave 1 as a single for prosthetic reasons. I believe it would be best to place 2 and try to adjust the paths of the 2 in a similar way. According to the paper, the best solution is a 3-unit bridge with 2 implants placed. That's what I wanted to point out. 13 and 15. Not enough for 3 implants, and 2 need to be placed. If teeth axes are different, can you splint them? That's something we need to think about, and I searched for the paper. I couldn't find canine implant related papers, so I looked at data in our hospital. Canine implant doesn't create problem. It moves on to the group function, whether it is standing alone or anteriorly splinted or posteriorly splinted without a problem. I believe the teeth axes were similar to splint them, or for some other reasons, and adjacent teeth and implants are considered. Complications in adjacent teeth occurred, but not much, not significantly. This can affect adjacent teeth. I believe that is the side effect of changed occlusion. The number 3 is changed in terms of occlusion. So the complications are occurring in the adjacent teeth. Reasons for extraction of single canine, congenital missing. When you place an implant at number 3 only, it doesn't get fractured or destroyed. When it is anteriorly splinted, periodontitis occurred. When it is posteriorly splinted, periodontitis or dentacaries. So for a single case, it's congenitally missing case, therefore you don't need to be concerned about that. Canine guidance for the single would not be appropriate, right? What do you think? I don't think you can apply canine guidance after placing a single implant. In this case, the antagonist is an implant RPD in the mandible. I don't do canine guidance for the implant. The implant itself should not receive lateral force, so the guidance is not applied. For the group function, the stiffness of the cusp is lowered. When it is anteriorly or posteriorly splinted, problems don't appear as much as we expected. In the canine, we can draw this conclusion. I really tried to look for the information regarding the different tooth axes for the implant. I tried to find the information for hours and days, and I couldn't find it. Regarding the implant with the different tooth axis, there is hardly any long-term reports. Therefore, there is no reason that we cannot do that. We don't really place them with very different axes. The angled abutment can be used to compensate the axis to a certain degree. Here, number 3 cannot be said functioning. Number 3 and 5 are placed. The shape of number 3 is designed as a canine, and number 3 and 5 can have different axes, but I try to align them in terms of the axis and made the prosthesis. Thank you. Listening to Professor Kim Young-taek, it occurred to me after surgery, especially recently, as I have been engaged in case discussion, I thank prosthodontists. When we place implants, sometimes inevitably, but still, it's hard to believe I place them myself. So I say during lectures that if you see very weirdly placed implants on x-rays, before you blame the surgeon, you need to think that it might have been you. And I came to appreciate what the prosthodontists are trying to do. We had a very good discussion with the similar cases. Based on what have been discussed, would you like to give us the final conclusion? Looking at this case, I don't believe number 13 was extracted long time before. If we wait, the buccal bone is very thin. If we are to do the bone graft, gap filling needs to be done. That means bone graft would not be very difficult. If you wait for a long time for number 3, you don't really have to do bone grafting. If the patient can wait, using the wired temporary, number 16 can go wrong. Then the case will become easier. So I hope the situation can be made easier. If you wait, in this case, number 16 will become easier. Even if you do bone grafting, you cannot do that on the outside of the thin buccal bone. So I don't think this is really challenging. We already reached the conclusion. We'll place one implant each at number 13 and 15. Number 13, you'll be able to place a 10 millimeter if you are not too ambitious with a length like 13 millimeters, so you don't need to touch the sinus. If it is healed, it will get better, but at 2 to 3 months, when the healing potential is the biggest, you'd better place the implant. At number 15, crystal approach instead of lateral. Because there is the slope, it would not be easy using just crystal. Distal to number 15, it looks like we can easily open the window, right? So crystal approach needs to be challenged first to place 2 implants, and we need to think about occlusion, as RPD will be used in the mandible, so occlusion with the RPD needs to be considered. Then I believe the implants can be used for a long time without a problem. I agree with Professor Kim. Number 13, on the CT, the labial bone is thin as it remains. Number 13, I don't think we need to touch sinus. In the past, we placed 13 or 15 millimeters. Now, 11 millimeter in canine is used pretty often. As Dr. Park said, if we remove number 16, things will get much easier. I believe the dentist who sent us this case to us to discuss is worried to do GBR and the sinus together. Not a major problem, and then you can place an implant at number 13, and then you need to use xenograft, which is being resolved slowly. At number 15, sinus graft can be done. It can be difficult because of number 16, but it's not a really difficult problem. In this case discussion, we talked about GBR and sinus lift, which is considered an advanced case. I'd like to thank the dentist who sent us the case and also the audience. This concludes the case discussion. Thank you very much, the panelists. Thank you. I'm MC Dr. Kim Se-jin. I'll see you next time. Thank you.
수고하셨습니다.